Hello and welcome back to Pharmacology with Dr. Sokolow. So today we are going to talk about pharmacodynamic. We spent a lot of time talking about pharmacokinetic, and if you remember when I contrast both pharmacokinetic and pharmacodynamic, I said that pharmacokinetic is what does the body do to the drug, and pharmacodynamic is what does the drug do to the body. And so that's what we are going to discuss in the next coming slide. So first we are going to talk about drug-receptor interaction, because this is the common way that drug interact with the body is by interacting on a receptor. So first let's talk about the receptor theory, which says that a drug must first be bound to receptive substance in order to produce an effect. And so that receptive substance, so it's a receptor most of the time that is located on the intracellular membrane of a cell. And so that's what describes a drug target. That's the cellular molecule to which a drug binds to initiate its effect. And so again, most of the time that target, it's going to be a receptor. So if you look at this figure, you see you have a heart, and they are like the receptor in green, and so the drug is going to bind to that receptor and trigger an effect. So if it's a cardiac cell, it can be to reduce like the heart rate, and so once the drug binds to the receptor, it's going to induce a signal that is going to slow the heart rate. So as I just mentioned, the majority of drug targets, they are physiologic receptors, which their normal function is to bind an endogenous ligand, such as a hormone or a neurotransmitter, and through that interaction between the ligand and the receptor, transmit a regulatory signal. And I'm sure you know that from your pathophys course. And so majority of the drug, they will target receptors, and here I have example of drugs that are targeting the nervous system. And so there are like 4 primary receptor family of the nervous system. You have the cholinergic, which has for endogenous ligand acetylcholine, the adrenergic system, and in that case the primary ligand, it's either norepinephrine or epinephrine. Then dopaminergic, guess what? It's dopamine. And serotoninergic, it's serotonin for the endogenous ligand. And so here I have listed 2 drugs that are used for the treatment of asthma. One is an anti-cholinergic drug, and that means it will bind to the cholinergic receptor and block the action of acetylcholine. In that case, will relieve a bronchospasm by producing bronchorelaxation. And the beta adrenergic drug will do the same thing by binding a different type of receptors. In that case, they are called beta adrenergic receptors, and prevent the action of norepinephrine on those receptors, and also cause bronchorelaxation. And we'll talk about this in detail when we come to the autonomous nervous system lecture, and so don't worry for now. It's just to give you an explanation of how those drug targets work. Those receptors most of the time are extracellular. They're located on the extracellular membrane of a cell, but in some case, like for the estrogen, they are nuclear receptor, and so in that case they are intracellular receptors. So on this slide, you have like the 4 primary receptors family. And so the first one is a cell membrane embedded enzyme. So as you can see, one, you have an agonist or the endogenous ligand that bind to that receptor. It will just activate an enzyme. Number 2, it's a ligand-gated ion channel. So again, the red part is either your endogenous ligand or the drug. And so if the drug activated, it will just open a ion channel. If it's an antagonist, it will just block and close that ion channel. Number 3, it's a G protein coupled receptor system. So in that case, when the ligand or the drug binds to that receptor, it will just activate a J coupled protein and induce a receptor through that mechanism. And then number 4, it's a transcription factor. So you see that one is intracellular, it's inside the nucleus, and that's how the hormone actually works. So you see when the ligand or the drug bind to that receptor, it will just activate the transcription. And so that's how those receptors operate. What you need to know is like, what are the different type of receptor families? So in order to interact, with the receptor, they are like different way they can interact and different type of binding between the drug and the receptors. And so first you have like the first type of binding are like chemical bound. So how does a drug can interact with a receptor? So they are interacting through binding, and those are chemical bonds because drug is a chemical, and so there are chemical bonds that form the binding interaction between the drug and the target, because the receptor is a protein and the drug is a chemical, and so they just are going to interact by a chemical bonds. And they are like different type, which are probably going to bring you memories from your chemistry courses. The first type of binding are the ionic ones. And so an ionic binding is an interaction between a negative charge and a positive charge. So they are like very strong bonds. Then you have the hydrogen type of interaction, which is an interaction between an hydrogen atom and a pair of free electrons on a oxygen or a nitrogen atom. And then you have the van der Waals interaction, which are weak interaction between dipole. And so the sum of all those interactions are going to be resulting in a more stronger binding. So the more forces you have between the drug and its receptor, the stronger the bonds are going to be, and then you're going to have a better fit and a higher affinity. Just let's imagine it's like a key in a lock, and so if the key fits well in the lock, then you have a strong interaction between the key and you can open the door. So that's pretty much the same. And so in that case, you're going to have a strong fit between the drug and its receptors. And if you have weak forces, so if the drug is kind of loose on its receptors, then you're gonna have a shorter duration. So how does the drug interact with a receptor? So they are going to interact through chemical bonds, because we saw that a drug most of the time it's an organic, it's a chemical, it's an organic compound, and the drugs, they are going to be like proteins, so they are going to interact by forming binding interaction between the drug and its target. And so there are different type of bonds. You have ionic ones, which is an interaction between a negative and a positive charge, so they're really strong bond. Then you have the hydrogen type of binding, so it's an interaction between hydrogen atoms and pair of free electron on an oxygen or a nitrogen atom. And then you have the van der Waals force, which are weak interaction between dipole, and all those type of interaction probably reminds you your chemistry course. So what you have to know basically is like different type of bond can lead to a stronger or weaker interaction between the drug and its target. And overall, those forces are summed, and more bonds means you're gonna have a better fit and a higher affinity. If you have weak force, if you don't have like strong binding between the drug and its receptors, that means you're gonna have a shorter duration. And so during the drug development process, they are studying the chemistry of the drug and then the chemistry of the receptors, and now they can do like 3D modeling using like computer science, and they can try to get the best fit between the drug and the receptors. And so that's the basis for receptor selectivity. So ideally you would want, you know, a drug that is only going to interact with only one type of receptors, and they are not going to bind to anything else. That would be, you know, the ideal drug. But selectivity, you know, doesn't guarantee safety, because, you know, if you have a drug that is really selective to one type of receptor, but is, you know, the binding is so strong that is not that is hard to be reversible, then it's going to last longer, and, you know, might be difficult in case of intoxication. It's going to be difficult to reverse its effect in case of intoxication. So like I said, you know, like in drug development, they study the chemical structure of the drug, and then they can determine, you know, its affinity and intrinsic activity with the receptors that they think would be a good fit. And then, you know, let's say you, or for example, if you have a drug that already exists, and we know, you know, what that drug look like, but it's kind of like a dirty, messy drug, and they want to make it a little bit like cleaner, less adverse effect, then they can modify the structure of that prototype drug to try to make it, you know, a little bit cleaner with less adverse effect. Or maybe you can give like fewer dose instead of giving it 2 times a day, you know, giving it once a day would be better. So that's how, you know, they can just modify, make like some minor modification in the structure, which can, you know, lead in major changes in the pharmacological properties. And those properties are pharmacokinetics property, you know, metabolism can change, and then therapeutic use. Sometimes, you know, you can just modify it slightly, and from an agonist you'll get an antagonist. Or you can also, as I said, you know, modify the side effect profile, which is, you know, most of the time that's what they are looking at, is like to make a drug a little bit safer. So let's talk about why stereochemistry is important in drug receptor interaction. So if you remember, most of the drugs, they are organic chemistry compounds, so that means they contain several like carbon atoms, and a carbon atom can have, you know, 4 substituents, and in the case of 4 different substituents that are bound to that carbon atom, you'll have a chiral carbon. And what does that mean? It means that that carbon cannot be superimposed to its mirror image. It's like, you know, trying to superimpose your left hand and your right hand. And so those two enantiomere that they are called, if you remember from your organic chemistry course, those two enantiomere can have the same property and bind the same way to the receptor, but in some situation, one enantiomere is going to bind stronger to the receptor than the other. And in real life, you know, when those drugs are synthesized, they synthesize what is called a racemic mixture, which means it contains 50% of both enantiomere. So you have 50% of the R and 50% of the S enantiomere. But also, like in drug development, they realize that sometimes, you know, you have an enantiomere that can bind better to the receptors and that it can be more effective in the treatment. So they try to isolate that enantiomere, but of course it's more costly to do that. And so here is have an example, which is albuterol or Ventolin, which is the racemic mixture, which means contain 50-50 of each enantiomere, versus levalbuterol. So levalbuterol, it's only the R albuterol, and that one is 100 times more potent. So it's going to be more expensive than Ventolin, but the advantage, you know, the patient may need less of that medication to feel like relief of their bronchospasm. So people who are refractory to albuterol, they may be switched to albuterol because it's 100 times more potent. And so those enantiomere also may have like different half-life, if you remember like the concept of half-life. And there are only like 45% of drugs that are pure stereoisomere, so isolated enantiomere, you know, either the R or the L. In most of those racemic mixtures that are used, you know, in drug therapy, they are like 50% of each enantiomer. In some case, maybe 50% is not effective. But again, this will be determined during clinical trial, and they will know exactly how much drug they will need to go to give in order to see an effect. So let's talk about thalidomide. So as you can see on this slide, thalidomide comes into different enantiomer because it has a chiral carbon, and so you see that the mirror images are different. So you have an S and an R. And so this drug was developed in the 50s and was proven effective against motion sickness and also was a sleeping aid. So it was given to pregnant women who had motion sickness during their first trimester. And what happened is like they saw an increase birth defects in those women who had taken thalidomide during their pregnancy. So the newborns were missing limb or missing fingers, and so after several years in investigation, they withdrew this drug from the market, of course, but they realized that it was the R enantiomer that has that potent properties against morning sickness. And so actually now they re-commercialize this drug in cancer treatment, but in that case they were able to isolate just the R enantiomer, and also in order to be prescribed, the provider has to provide guideline to their patient, and also it's not recommended to pregnant women, of course, and monitoring of this drug is very heavy. But because the benefit of having such a drug in cancer therapy is important, they decided to bring it back to the market, but just only the R enantiomers. They realized that the S was the one that was teratogenic and was leading to birth defect. So until now, we talk about, drug-receptor interaction as the primary way that a drug can exert its action on a cell. Now, there are some drug response that do not involve receptors, and let me tell you what they are. So what are the other drug targets other than receptors? So first, you can have an inhibition of an enzyme, and that's the case of the NSAID and the IMAO, or the inhibitor of the monoamine oxidase, which are drugs that are used for the treatment of depression. And so the NSAID, these are more common. They are your ibuprofen, your aspirin. They bind to an enzyme that is called COX. At this point, I'm not asking you to know the name of the enzyme. We'll cover this when we see the anti-inflammatory in detail. But what you have to know is this is an example of another target. It's an inhibition of an enzyme. Then you have some drug that can bind to membrane transporter. One example is cocaine, which binds to the dopamine transporter. Again, you don't need to know which transporter it binds to, but you just have to know other example of drug target. And then you have the drugs that are receptorless drugs. They're just acting by their physicochemical properties. For example, the antacids, so they are drugs that can neutralize the acid in the stomach, and it just do it because they are more basic drug and they will neutralize the acidity. That's, for example, your thumbs. Then you have drugs that are chelating agents, so they act by chelation, which means they are going to bind, to a molecule, and these are used, for example, in toxicology to remove some drugs in case of intoxication. And then you have the laxative that are also acting based on their chemical properties, and some they use just osmosis to help pass stool. That's how they work, and so they don't bind to a receptor, they just act based on their physicochemical properties. So the interaction between the drug and its target, regardless if it is a drug receptor interaction or a drug enzyme interaction, that interaction is usually reversible. But in some case, it can be irreversible, especially if electrons are shared, like with a covalent bond that is really strong. So in that case, the binding, it's irreversible. And one example is the inhibition of the COX enzyme by aspirin. So I said that the NSAIDs are working by inhibiting an enzyme, and the name of that enzyme is called COX. And so aspirin binds covalently to the COX enzyme and is going to inhibit that enzyme during the lifespan of the platelet. So a platelet's lifespan is about 6 to 8 days, and so this inhibition will last during 6 to 8 days. And of course, aspirin is not going to bind to all the COX enzyme in all the single platelets in the body, so you're going to have an inhibition of certain enzyme of those platelets, and that will cause the anti-aggregant effect. But that's how aspirin binds, and that's an example of an irreversible binding between a drug and its target.